In our last section, we walked through the technology landscape, the EMRs, the point-of-care tools, the telehealth platforms, the scheduling systems, the billing engines. We looked at how home health finally, after 15 years of being behind, is sprinting to catch up. But I told you at the end of that section that one technology stands apart from all the others. One technology is not just another tool on the shelf. One technology has the potential to rewrite the economics of this entire industry. That technology is artificial intelligence. Now, I want to be honest with you up front. AI has become the most overused, most misunderstood term in business. Every vendor at every conference has AI powered, something on their booth. Most of it is marketing. Some of it is real. If you're an agency owner trying to make a decision, or a clinician trying to understand what's coming for your job, or an investor trying to evaluate a company, separating the real from the noise is hard. So let me do my best to cut through it. I want you to meet Sarah. Sarah is a registered nurse. She's been in home health for 19 years. She's the kind of clinician every agency would clone if they could. Steady, compassionate, unflappable. Her patients love her. She remembers their grandchildren's names. She notices the little things that matter. The way someone's shirt is buttoned slightly off one day. The tremor that wasn't there last week. Sarah was going to quit last March. Not because of the patients, not because of the pay. Though the pay is always a conversation, she was going to quit because of what happened every night after her husband went to bed and her dog curled up on the couch beside her. She would open her laptop at 9:30 p.m. and she would start charting. The visits she had done between 8 a.m. and 5 p.m. were still waiting to be documented. 7, 8, sometimes 9 visits, each one requiring a detailed note that captured what she observed, what she taught, what she planned, what the patient said, what the family needed. The OASIS assessments, those are a different animal, and we'll get to them. Add in the care plan updates, the communication notes, the coordination with physicians, and on a normal Tuesday, Sarah was doing 3 hours of paperwork on top of full day of patient care every night. She told me once, and this is a direct quote, "I became a nurse to take care of people. I didn't become a nurse to type." Sarah's story is not unusual. Sarah's story is the story of home health, depending on which study you believe. Clinicians in our field spend somewhere between 35 and 45% of their working hours on documentation. Almost half of the time of our most scarce, most expensive, most mission-critical resource is spent on paperwork instead of patients. For 20 years, we've known this was a crisis. For 20 years, we've tolerated it as the cost of doing business. And now, for the first time, we have a technology that can actually do something about it. That technology is artificial intelligence. And I want to spend some real time with you on this because I think it's the single most consequential shift happening in our industry right now. Let me be careful with my language for a moment. When I say artificial intelligence, I don't mean robots. I don't mean some autonomous system making clinical decisions. I don't mean replacing Sarah. Anyone selling you that vision is either confused or trying to sell you something dangerous. What I mean is software that has finally gotten good enough to understand language, recognize patterns, and do the boring parts of the job that have been crushing Sarah for 19 years. The biggest application, and this is the one to focus on, is called ambient documentation. Imagine this. Sarah walks into Mr. Rodriguez's home. She has her phone in her pocket, running a small app. With Mrs. Rodriguez's consent, the app is listening. Sarah does what Sarah does: the assessment, the wound care, the medication review, the teaching, the family conversation. It's a normal visit, maybe 45 minutes. Sarah walks out to her car. Before she drives to the next patient, she opens the app. The AI has already drafted the visit note. It's structured properly. It's in clinical language. It's pulled the vital signs from what Sarah announced out loud. It's captured the wound measurements Sarah mentioned. It's drafted the teaching note based on what Sarah taught. It's even drafted the skilled need justification, the magic words that Medicare auditor needs to see. Sarah reviews it. She edits 2 sentences. She approves it. Total time, 5 minutes. Compare that to 45 minutes it would have taken her to write it from scratch at 9:30 p.m. That's a 40-minute difference per visit. Times 8 visits a day, times 5 days a week, times Sarah's entire career. You do the math and you get Sarah back. You get her home for dinner. You get her not quitting. And that technology exists today. Not in a lab, not in the future, today. Companies like Nuance, DAX, Abridge, DeepScribe, and Suki have been deploying ambient documentation across healthcare for years now. The accuracy is getting to a point where clinical review takes minutes, not hours. The home health specific versions are coming fast. Now, there is a slight difference because in the hospital setting, when the doctor is communicating with the patient, it's all that communication that gets transferred to a note. However, in OASIS assessment, there's a lot of clinical observation that needs to happen. And that's why somebody who understands the OASIS assessment, the start of care, the resumption of care, recertification, visit note, transfer, discharge, that's the kind of team that can actually build the OASIS coding module. And there may be some gap questions that would need to be answered after the start of care assessment is done. There may be another review that might take even 10-15 minutes for a regular start of care visit. So it is getting there very fast. Let's talk about OASIS coding. If you've ever sat with a new clinician trying to complete an OASIS, you know it's its own special kind of torture. Hundreds of items, nuanced definitions, scoring that drives payment, drives quality measures, drives star ratings. Get it wrong in one direction and your agency loses money. Get it wrong in the other direction and you've committed fraud. It's a high-wire act, and it's a high-wire act that has to be performed 5,000 times a year by an agency of decent size. AI is becoming extraordinarily good at coaching OASIS. Not replacing the clinician's judgment, that's still her job, but catching the inconsistencies, flagging the contradictions. Hey Sarah, your narrative says the patient needed moderate assistance with bathing, but you quoted him as independent. Do you want to take another look at that? That one check, applied consistently, is the difference between an agency that gets its coding right and an agency that doesn't. That's the difference between payment accuracy and payment erosion. That's the difference between a strong star rating and a mediocre one. Then there's clinical decision support. This is where AI starts looking at patterns across your patients and whispering in your ear. Which of your patients are at the highest risk of hospitalization in the next 30 days? The AI knows because it's looking at vital sign trends, medication changes, recent visit notes, and comparing that pattern to thousands of previous patients who did end up in emergency rooms. Which patients are at highest risk of falling? The AI has an answer. Which wounds aren't healing the way they should be? The AI can tell you before your clinician's next scheduled visit. This is the shift from reactive care to proactive care. You stop waiting for the crisis. You intervene before the crisis happens. And then there's the operational stuff. AI is going to quietly revolutionize scheduling, not just route optimization, the old version, but real pattern learning. Which clinician works the best with which patient, which combinations of visits on which day produce the best outcomes, how traffic on Interstate 35 at 3 p.m. on a Wednesday will affect your afternoon route. The AI figures it out. Your operation team doesn't have to. Same thing in revenue cycle. AI can look at a claim before you submit it and tell you with surprising accuracy whether this claim will get denied before the payer ever sees it. You fix the problem up front instead of appealing 6 weeks later. Now, I need to be honest with you about something because I don't want to sell you a fairy tale. AI is not magic. It's not going to save a badly run agency. It's going to amplify what you already are. If your data is messy, your AI is going to give you messy insights. If your clinical documentation is inconsistent across clinicians, your AI is going to encode that inconsistency. If your clutter doesn't trust new tools, your AI is going to sit on a shelf while people work around it. AI also makes mistakes. Ambient documentation hallucinates sometimes. It generates a sentence that sounds right, but isn't quite right. That's why the clinician always has to review and approve. This is not autonomous. This is assistive. The clinician stays in the loop, always. And then there's the privacy and security question. Where is the data going? Who's looking at it? Is it HIPAA compliant? Is your BA in place? Is your cyber insurance going to cover it if something goes wrong? These are not optional questions. These are the table stakes for deploying AI in a regulated industry. But with all of those caveats, and they are real caveats, the trajectory is clear. The agencies that figure out AI in the next 2 years will have a structural advantage over the agencies that don't. Not because they'll have better technology, because they'll have Sarah. And Sarah will still be there in 5 years. And the other agencies, Sarah, will have quit. That's what AI actually gives you. It doesn't give you robots. It gives you back your people. And in a workforce crisis, there's nothing more valuable than that. Before we move on, I want to leave you with one more thought. There's a lot of fear around AI in healthcare. I talk to clinicians who are worried it's going to replace them. I talk to agency owners who are worried they'll get left behind if they don't adopt and sued if they adopt wrong. I talk to investors who are worried they're either too early or too late. Here's what I tell you. AI is not going to replace clinicians. AI is going to replace clinicians who don't use AI. That's a very different sentence. The home health nurse of 2030 is not going to be less skilled than Sarah is today. She's going to be more skilled because the paperwork that consumed her predecessor's evenings is going to be handled in few minutes, and the hours she gets back are going into the work that only a human can do. Listening, noticing, teaching, comforting, deciding. The tool is powerful, but the hand holding the tool still matters. Now, AI needs something to work with. It needs data, and the data needs to flow from hospitals, from physicians, from pharmacies, from every other corner of the healthcare ecosystem into your system, where the AI can actually do its job. Which brings us to the next section, interoperability, the plumbing of modern healthcare, and a fax machine that refuses to die. Let's go.